So Noah's talk is on Reinvigorating Stagnant Science, Implementation Laboratories, and Meta Laboratory. So who is Noah Ivers? He is a family physician at Women's College Hospital. He's a scientist at Women's College Research Institute and an innovation fellow at the Women's College Institute for Health System Solutions. He is an associate professor in the Department of Family and Community Medicine and at the Institute for Health Policy, Management and Evaluation at the University of Toronto, and holds a Canada Research Chair in the implementation of evidence-based practice. He sounds like our kind of guy, doesn't he? What an awesome bloke. Now, we're going to have to do this a little bit differently because we can't teleport him here for this and back home again straight away. What's going to happen is that we're going to play Noah's talk, and then you see these 4 chairs here. We've got 3 amazing people lined up for you to sit on these 4 chairs. I will let you work out which one is not amazing. No, just kidding. 4 amazing people, and we're going to have a little fireside chat in the absence of Noah, but that includes you all as well. So over to you guys.
Thank you so much. And before I get going, I want to apologize for not being able to be there in person. I was so looking forward to joining you all at this wonderful event. I'm really happy to be able to share this recording with you. And I look forward to future collaborations in person. Let's dive in. Before we get too deep, a couple caveats, and I'll have a bit of preamble too. First of all, as you can tell by my accent and from the introduction, I'm Canadian, sort of like Australia, but colder, a little more ice hockey, a little less rugby. The other thing to sort of offer as a caveat is that everything I'm about to say is things that I've developed in partnership with others, and really by standing on the shoulders of giants in the field, mentors who have become colleagues, and I'm really grateful for all that they've contributed. All right, a little bit of preamble before we dive in as well. You know, I think if we're going to talk about implementation science, from my perspective, I like starting here at the beginning. And, you know, what we have here is a picture of the first guideline. And as we know, you know, this guideline is not all that well implemented. And that's because, you know, guidelines in general do not self-implement. And so, you know, it's important to keep in mind that as good as the evidence may be, that doesn't necessarily lead to a change in practice or in behavior. So a little bit more about what it is that I mean when I'm talking about implementation science. I like to reference this really great teaching tool by Jeff Curran. And I think the starting point is thinking about the evidence-based practice that we want to implement. He calls that the thing. That's the thing that we know is the right thing to happen for the patient. And we have effectiveness research that convinces us that that thing works. And so the question arises about, you know, how do we go about getting people to do that thing, to put the evidence-based practice into the real world reliably every time in the right way? And so we come up with implementation strategies that we test. These are things we do to make that thing happen more reliably. And we measure implementation outcomes, that is, you know, how much and how often and how well they're doing the thing so that evidence-based practice is happening and patients' outcomes are improving. So you can see this sort of framing helps us understand that when we're thinking about implementation science, we're thinking further down the pathway. We know already that something is good and right and helpful for patients, and we're asking, what is the way to make it happen reliably in the real world? All right, so having that out of the way, and I'm sure a lot of you are already aware of, you know, typical ways of thinking what is implementation science, I want to talk a little bit about some motivating examples for this talk and for what we're going to dive deep into together. And sort of the first one is sort of a typical, what I would describe as sort of a typical integrated knowledge translation approach to doing a policy relevant evaluation. This was a really exciting and fun project that I did with just a wonderful team of folks in Ontario, which is the most populous province of Canada. We worked with the government, with the health system decision makers, who identified this really important problem of overprescribing in nursing homes. Long-term care homes is another phrase for them, where people were too often getting antipsychotics as basically chemical sedation. So, we have a basically complex issue, a lot of it boiling down to understaffing, and people with advanced dementia. It was decided it's not appropriate to give them physical restraints, too often being managed with chemical restraints instead. And those chemical restraints, namely antipsychotics, carry a huge burden in terms of risk of side effect. So if you give patients antipsychotics, for sure, they're not going to be running around the halls and falling, true, but they may be falling for other reasons, or they may have cardiovascular effects that lead them to hospitalization and so on. They're really nasty drugs if overused. Of course, everything has its place. It's just we had data that Ontario is one of the highest use areas for these drugs in the world, really. It's a real problem. We wanted to work together with policymakers on addressing it. We actually convinced them that in addition to a bunch of other interventions, it might make sense to organize a randomized trial. So we did a cluster randomized trial of academic detailing in nursing homes, really exciting stuff from an academic perspective. These are the relevant papers if you want to look them up. We were able to do this in a real pragmatic way using outcomes from administrative databases. We were able to embed a process evaluation, all good and exciting stuff that we did way back in the different world before the pandemic. And whether or not it worked is not really the point of this talk. What I want to talk about is this integrated knowledge translation effort that we made and what we learned from that, what I learned from that. We really worked hard to engage all sorts of partners, not just the health system decision makers, but organizations that represented patients, of course, and residents of these homes, the family members and caregivers, the list goes on. And one of the challenges really was that, we were the evaluation partner, but we didn't really have control of what exactly was the intervention strategy, or even the specifics of the topics that would happen in these nursing homes. And the operations team responsible for that, who became our good friends and colleagues, they really needed us to adapt some of the things that we were planning to do from an evaluation perspective, including the randomization plan. So this kind of compromise was arising that was necessary. If we wanted to run a trial, we had to make these compromises. Okay, no problem. And then on the policy side, again, we made friends with the policymakers responsible for oversight of this sector of the health system. And it turned out that by the time we could get data out of the administrative systems and analyze the trial and provide them this excellent sort of set of evidence, not just quantitative, but qualitative as well, the key decision makers, they were still keen on learning about it, but their bosses had actually changed and were focused on other issues. So there was the politics of policy decision making kind of shifted gears. And most concerningly, we put all this work in over the course of numerous years. We did this really rigorous work. And from the policymakers' perspectives, really, this was a one-off demonstration project. That was actually the phrase they used. And so all the learning, it kind of didn't have a place to go. I went and we did our best with it. Of course, we published, but it didn't turn into a program. And that was incredibly frustrating for me. Maybe some of you have experienced similar. Just want to put a pin in that. Talk about a motivating example number 2 for the rest of this talk, which is, the sort of the literature of what I would describe as audit and feedback. Audit and feedback has lots of synonyms: benchmarking, clinical performance feedback, etc. This is an example report from Ontario that primary care clinicians can sign up for, namely family doctors. They can sign up to receive these reports about antibiotic prescribing, cancer screening, how they're doing for diabetes, and so on. You see on the screen, it compares them to their peers, lets them know about their practices. Pretty common stuff, pretty much ubiquitous in advanced health systems around the world now. And I've done I've done a ridiculous amount of thinking about, how this ought to be done. I've spent more hours thinking about that than probably any human should. We led the Cochrane review on the topic. The prior one was published in 2012, included trials up to the end of 2010. We have a new one, hopefully coming out next year, I hope. Anyways, the prior one summarized the evidence that audit and feedback improves quality of care by about 4%, absolute improvement. So if you were doing things the right way 50% of the time, on average, after an audit and feedback intervention, you'd bump up to 54%. But we found that the interquartile range was huge. A quarter of the trials found no effect at all. A quarter of the trials found an absolute improvement of 16% or greater. And the question obviously arises, how do we get more often the audit and feedback to achieve that bigger effect? The Cochrane review suggested, the items on the screen there, that there is some proven ways from the literature, from theory, that we can get a bigger effect more reliably when we're trying to improve quality of care using audit and feedback. You see them on the screen. They all kind of are, more or less intuitive. And it's nice, when intuition and the evidence align. Because you'd think that would mean we could move forward with more effective interventions thereafter. The problem is that that's not what we saw in the literature at all. In fact, we parsed the literature really carefully. We said, look, if we had stopped, if we had done our analysis of the Cochrane review in 2006, we would have come to the exact same conclusions. That this is about the effect size, and these are the ways to achieve a larger effect size. And yet we saw no change, no trends, no differences over time in how the audit and feedback in these trials were done, or in the effect sizes that they achieved. And so this is a real frustrating thing to realize. We're doing all this work, trial after trial, publishing, and we're not learning. It dawned on me that what we needed to do was not ask, does audit and feedback work? We know that. 140 trials, come on. We don't need another 140 trials. By the way, we've done those 140 trials. I have them in the updated review. We don't need 140 more, though. What we need to do is ask a more nuanced question, which is who will respond best to what kind of intervention? How do we get the most out of our quality improvement efforts? That's the Holy Grail. And to answer questions like that, questions that live at the center between sort of quality improvement questions and comparative effectiveness questions, we need large pragmatic trials. The problem is that large pragmatic trials, especially a program or series of them, that's not how our research funding is set up. Our research funding and current incentives are set up to just produce more of those one-off trials, asking, does audit and feedback work? Did our did our baby, our little intervention in our center or our region make a difference? And those they're not helping us as a field to learn. All right, one more motivating example, and this sort of takes us back, some number of decades to a legendary thinker called Don Campbell. His textbooks are, just the best, to be honest. And he had this phrase in one of his texts. And if you want, I'll just pause for a moment if you want to read it. But basically, he's talking about how frustrating he finds it that we're not using evidence to inform what we do for social programs. And I really like that, at the end, programs are continued or discontinued on inadequate or other grounds. How frustrating to set up a society that way. And in fact, that's the way things still are. And it stands in stark contrast to one of the stated definitions of implementation science, which is the study of methods to promote the integration of research findings into healthcare policy. Oh, these are, how can both these things be true? It must be that we're not doing implementation science right if what Don Campbell identified 50 plus years ago is still the case, and clearly it is. Made me start to wonder, where does implementation science research happen? And where should it happen? Started wondering what's the definition of a laboratory? Looked it up in a dictionary. And, we see it's a place providing opportunity for experimentation, for practice in a field of study. And I started to wonder, do we have that? Do we have labs in implementation science? It seems to me that, when I apply for a grant to do implementation science research, I have to sort of set up the lab and do the research all as part of the grant. And that seemed to put me, I felt like I was behind the 8 ball. I don't know if they use that phrase in behind the snooker ball. Anyhow, a summary of the preamble, if you don't mind. So number one, traditional stakeholder engagement, as I was taught to do in my training, it doesn't seem to be quite enough to achieve sustained program improvements, and it's definitely not enough to advance the field of implementation science. I think audit and feedback literature, because I'm personally so familiar with it, I think, it offers, a clear illustration of how we've wasted opportunities. We've wasted time, we've wasted money, we've wasted energy. We're often asking the wrong question in that field. I assume other subfields as well, because we're not really advancing our knowledge. And in fact, point number 3 is that this is not a new problem. And it's a core challenge for the field of implementation science. Maybe what we need is a new place or a different way to work. So a few years ago, with my mentor and very good friend, Jeremy Grimshaw, I think I was whining about this to him, and we developed together this, phrase, for lack of a better word, of implementation science laboratories. And we conceived this and wrote it up in the Lancet as a way of addressing research waste. Really lamenting what we saw in the audit and feedback literature that I've just tried to talk to you about, and really emphasizing that what we needed was a way of, partnership-based work that helped move the field of implementation science forward. We started to imagine in audit and feedback literature, as an example, a strong partnership-based approach where the implementation science researchers and the health system partner responsible for carrying out audit and feedback initiatives already in a health system work together to sequentially optimize over time and over the course of numerous trials over time the initiative that was going on. So as an example, a health system may already be doing audit and feedback, and most are actually. And it would be easy to embed a question within that existing initiative, we thought, to say, hey, let's alter this theoretically informed sort of aspect or component of the intervention and create version A and version B, and let's test them in a trial. Look, the health system is already rolling out the initiative. It wouldn't be a big added cost or challenge to compare whether version A or version B is different. In fact, the organizations that are most successful in the world right now, from a corporate perspective, Amazon and Google, they do this millions of times every day. They do A/B testing. And so we sort of drew from that inspiration and said, why don't we do this to advance implementation science knowledge? Because if version B is better, as you see in the image, it could become the new standard. And then, we might try version C and compare it not only whether it's better, but is it more cost effective for the organization and for the healthcare system? Maybe it's not, and maybe B remains standard and we test against D and so on. But as we do so, we can do things that aren't just asking things for local purpose, but we can ask things that inform generalizable knowledge about how to optimize audit and feedback, not just in a context or setting like this, but perhaps to inform it for other contexts or settings. So we published about that, and at the same time, we started building a lab, an implementation science laboratory focused on audit and feedback in Ontario, partnered with what at the time was called Health Quality Ontario, which was sort of came out of a new legislation that really encouraged the government to focus on improved quality of care, which is really exciting times. Things have changed since, but nevertheless, we have our ongoing partnerships that we've built, which is great. We've done a huge number of projects with this group, which is the sort of agency that helps run the health system in Ontario. This is a subset of the clinicaltrials.gov's trial registrations. There are others. Just to basically highlight that we've been able to work with them to sequentially ask questions, embed it in the work that they were already doing in different areas of the health system at scale, which is really exciting. And what I want to talk about as we go forward is basically what we've learned from that experience. And I hope I'll touch on a variety of things that you might take going forward for your own efforts. One of the things that that we were able to learn together, and that this goes back to the same clinical topic that I highlighted before, and that traditional approach to sort of integrated knowledge translation was, in nursing homes and long-term care homes, that's LTC, there was still this issue of too much antipsychotic use, and we sort of identified that amongst the physicians that were engaging in audit and feedback more, their antipsychotic use was going down. In comparison to the red line that you see, it was going down less quickly. And so it raised the question, if you build it, will they come? Well, not necessarily. There's a whole bunch of clinicians that don't necessarily engage with quality improvement interventions. This became a huge area of interest for our collective partnership together, in large part because it spoke to an issue that really motivated our policymaker partners, which is the issue of bodies and dollars. Really, that's what they need to know about. They need to know about return on investment, and so this because we had built a partnership over time, when the issue of budgets came up in a way that threatened their ability to keep doing the good work that they were doing, they were able to, lean on that partnership and work together to conduct an economic analysis, and showed, yeah, actually there's an amazing return on investment when people actually engage with the intervention. I mean, this is not exactly rocket science, but putting the numbers together for them made a huge difference in our collective ability to keep moving forward. So just to highlight that, because we had built the partnership, we were able to take a tangent away from our scientific sort of goals at the time and help them, sustain the program so that we could then return to our scientific work that interested us more. And actually asking the question about how do we address engagement became really, really interesting from a scientific perspective. I just, take a moment to highlight something. This was the initiative that they were running specifically related to cancer screening. One of the detailed reports, an example of a detailed report that I could have gotten, a decade ago. And it allows to dive deep into patient level data and to see which patients are overdue for cancer screening. And what you see on the right of your screen is this lovely email written presumably by a lawyer that entices me to log into this detailed site. And you can see how enticing the words are there. And you can see how somebody like me, who knows what's deep underneath, might be liable to click through and go use the data. And you can probably see how somebody who's not so much like me probably would quickly skip by that email because it doesn't seem all that interesting or actionable. And we thought, we can probably do something about that. And so we did. We worked together with our partners and said, we think we can get more people to engage in your audit and feedback work. Why don't we use the cancer one as an example? We can then apply it to the other sectors. And in fact, we ran a complex 2x2x2 factorial trial testing different email content that we co-designed, co-developed with end users. It was really fun work. We actually showed through this little trial that we increased pap smear screening, cervical cancer screening, that is, in the province by thousands of patients in a short amount of time, simply by altering the email content. This was pretty fun stuff to work on. So it can make a difference just in ways that you weren't necessarily expecting to, was the lesson learned there. What we started to realize then is other organizations around the world were struggling to get end users to engage with audit and feedback initiatives. And so it dawned on Jeremy and I and others that one could imagine a metalab. So if you have an audit and feedback implementation science laboratory in Ontario, it could interact with a similar one in Scotland and in Australia and in Leeds in the UK and elsewhere, as we started to do, and share learnings and actually start coordinating our activities to try to more efficiently move forward the science. So this was something we, again, it's pretty intuitive. It's not exactly rocket science, but we wrote this up in BMJ Quality and Safety, if you want to read more about it there. And we think it's an important way to start thinking about moving forward implementation science in a more coordinated way, much in the same way that if you think about how the field of pediatric cancer so rapidly advances, thank God, its ability to determine best possible approaches to treat kids who are suffering. You see these trial centers of excellence working collaboratively around the world to start this started maybe 30 years ago to start basically enrolling almost every kid who has leukemia, gets the best practice now. And that's because of efforts, in basically trial centers around the world. We started wondering, could we do something similar in implementation science? So, so by all means, please read, Google those things and read about them from the papers we've written. They're open access. I want to spend just a few moments now talking about the actual practical aspects. What's it like to operate an implementation science laboratory? Because it's kind of a different way of doing science. I wouldn't say new, but it definitely involves some challenges along with the opportunities. And I want to just spend a few minutes talking those things through. First thing I want to lay out is how it has worked in my experience in terms of task splitting. Who does what? Who's in charge of what? Who's accountable for what? We have on the one hand the research team, and on the other hand the health system leaders. And each have their own accountabilities, and each have a different set of incentives, if we're being honest, right? So who's in charge of what? Well, the research team is responsible for bringing to the fore what the evidence gaps are. The health system, in my experience, really is responsible for engaging with the vast number of stakeholders that might be involved in receiving or acting upon the quality improvement intervention that they're rolling out. They have their reputation to manage, and they need to think about risk in a way that is different than the way that the researchers tend to think about risk. And so that's really something important to recognize when we're thinking about what is it that we want to work on together. And so, I think these are usually unstated, and the quicker one can get the relationship to a point where they can be made explicit, the better. Now, in terms of getting to the actual meat of, doing a trial together, for instance, in my experience, it's the research team that's responsible for coming up with outcome measures and hypotheses that ought to be tested, but it's the health system that's responsible for making sure that whatever's going to go out in the field is actually going to be acceptable to the end users, as I mentioned, but also, it's their job to tell us as researchers what's feasible. They're the ones running the intervention. It's their intervention that they're allowing us to modify. And as a result, it's really, we need them to tell us what's going to be sustainable. And, for instance, if we add a co-intervention that costs a lot of money, we need to ask questions like, what kind of return would you need to sustain this? They might actually say it doesn't matter, it's cost prohibitive. It doesn't matter what the return on investment is, we literally wouldn't be able to find that money to keep spending. And so that totally changes the list of possible interventions or modifications that the research team can think through. In terms of evaluation, data collection, when it comes to audit and feedback, this is pretty easy. The numbers needed to produce the feedback reports are the numbers needed to be collected to know whether quality of care has changed. And so, those routine data that are collected anyways, that's been the responsibility in my experience of the healthcare system. Whereas any extra data, surveys, interviews, other sources of data collection, that's stuff we have to write grants to fund. The health system will want to conduct their own program evaluation. They'll want to know what the return on investment is. They need to constantly make a business case. We're there to help them, because if their program falls apart, we lose the sandbox in which we're playing, as we talked about just moments ago. But that's not really the area of interest for us. what we want to do is causation and causal explanation. What we want to do is focus on generalizability. We want to use this lab to learn enough and inform what can be done in other labs. What's the interaction between context here and what we've found? And how does that raise questions for things we should ask in other labs? And so, the health system is responsible for making program decisions. Should we keep this going or not? We want to help them with that. But our job really as researchers wanting to advance the field of implementation science is theory testing and theory building. So sort of to summarize what that all leads to is, the opportunity for, incredible, through the relationships, incredible sharing of not just explicit knowledge, but tacit knowledge too. Once you have the relationship, you can learn from them the things they're doing to make the intervention work in the field, in the real world. You can learn, you can have the opportunity to learn with them about how to address issues of spread, scale, and sustainability. These are massive, massive areas of interest for the field of implementation science that we really can't address other than, in my experience, through these kinds of partnership-based work. And we can do all sorts of really interesting methods that, as I said before, address causal attribution, causal explanation, and that help us through a programmatic approach address the idea of sequential effects on quality over time. Again, an area that's totally ripe and open and not been properly thought through or theorized because we haven't had the lab in which to do it. But there are some challenges, of course, if we're to build labs like this. The health system partner, they need to compromise. They need to be able to go to whoever is funding them and say, yeah, we're testing this stuff because, to be honest, we're not sure if it works. I mean, that puts them in a really dangerous position sometimes. They have to be willing or able to go there or to work with you as the research team to decide in which areas they're willing or able to go there. From the researcher's perspective, it really requires a great deal of compromise too. The amount of time that I've spent building relationships that, don't go on the CV, don't, end up really anywhere, don't necessarily lead to outputs that end up on my CV either. Like, these are huge investments of time because you feel like it's going to return something meaningful later, and because it's fun and interesting. And I think not every scientist is in a situation where they can make that kind of investment. Nor is every scientist going to be comfortable with sort of compromising in terms of control over topic, outcome, intervention, other decisions to be made in what they might see as their lab. This isn't their lab, it's a shared space, isn't it? So it's a different way of working. And it might very well require different kinds of incentives for scientists going forward if we want them to work this way. Okay, a few minutes in terms of work in progress, things that I've been thinking about over the last little while as it relates to implementation science laboratories. What I'm about to talk about now hasn't yet been published anywhere, and would really love feedback on these things as we continue to think them through. First of all, sort of it's come to light from my perspective at least that there's probably at least two types of implementation science laboratories. One is vertical. That's the one I've talked about, through this talk, where we focus on a specific implementation strategy, audit and feedback in this, in the examples that I've used today, and we try to understand it across a range of contexts and use cases, and really go deep there. But there's another kind of implementation science laboratory that's cropping up. The NIH has funded a whole series of implementation science laboratories that focus on cancer control. And so this is what I would think of as a horizontal kind of laboratory. The idea is to focus on a care topic or condition, and one might use a whole range of implementation science, implementation strategies in their scientific approach. And so, one could blend these or not, but it's just one more way of thinking about what the activities are that are going on in an implementation science laboratory in this place that we're trying to do the work of advancing the field of implementation science. We've also done some thinking about what it means to have an implementation science laboratory. What are the key features? What makes it an implementation science laboratory? And we have 5 characteristics that Jeremy Grimshaw and I have come up with listed here, and a starting point at explaining them or defining them. Again, this hasn't been published, but you can see here really an emphasis on stuff that I've already talked about actually in this talk right now. An emphasis on collaboration and engagement with partners. We talked earlier around how important it is that the lab is there to provide an opportunity to engage at scale, because it's when initiatives are done at scale that we can test nuanced features of an initiative to understand what works better than something else and why or why not. The other aspect that we've sort of talked about is sort of the programmatic approach that is enabled when we know that there's a sustained intervention going on over time, which gives us the opportunity to test issues of context, intervention, interaction. It gives us the opportunity to understand change over time, and so on, to really purposefully think through things like fidelity and adaptation. These are really, really core issues that need to be unpacked in implementation science. And of course, at the bottom, an implementation science lab has to focus on advancing implementation science. And this is key. I'll go to the next slide. This is the differentiating factor from my perspective of other sort of common or related terminology that's out there as it relates to sort of embedded research or integrated research that makes this maybe a little bit of a different way of doing work. One might think of the implementation science laboratory as a sort of subclass or subtype of a learning health system, where explicitly the goal is to focus on advancing implementation science, and where explicitly there is a collaboration in terms of the decision-making between researchers and health system leaders. Again, this is a work in progress. This is something we're still thinking through. How does this concept fit with other similar or related concepts as it relates to research structures, or similar or related concepts as it relates to research processes, ways of doing work? I'll leave that for discussion or further thought. And I want to sort of just highlight again how grateful I am to have been invited, how sorry I am to have not joined you in person. I would be thrilled to hear from any or all of you. I'm pretty easy to find online. I tend to respond to email quite quickly unless I'm busy in clinic seeing patients and perhaps am feeling frazzled, like that picture there. And again, a quick note of thank you to those who fund me and to my mentors who have become my colleagues. And as I close the talk, I just want to leave up this slide here, and I hope that it might inspire thoughts or questions or just good work as we all sort of share in the aim of improving quality of care for the patients we serve. Thank you again.
That was a fascinating talk. I really appreciated that perspective. It definitely went along with the theme of we've got enough evidence. What are we going to do now? Right? Let's not keep studying the same thing. Let's just not do research or studies just for the sake of doing it. Also a theme about relationship building and the importance of that. That ties into everything we've talked about today. Really interesting concept on the laboratories and how that would be set up. As he was presenting, I was thinking as the health system side of it, what that would look like, what our goals would be, both short-term and long-term. Because a lot of the time when we're doing implementation work, we're doing it now. And so the health system would definitely need to be invested into the long-term study of implementation science, which many are. But the pressing need is more, what are those implementation strategies that we need to look at now?
Is it really feasible for a health system, so the service side of things, do you think, to have that future long-term perspective and set up a laboratory-based approach to implementation science? Like, is that really feasible?
When I was watching that, the one word that came to mind was aspirational. From a health service perspective, I definitely think it is feasible, but I think there's a lot of steps before we can actually get there. And I think the one thing about today and from that presentation is that implementation, it is that spectrum. It is that, we will have those local small projects, but we will also have, those bigger hybrid type studies and buy-in from the health service. And we need to have that spectrum, I think, across the health service if we're going to be successful in implementation.
I totally agree. I think having the spectrum, having the spectrum is what's needed, because you can see that there's still going to be a need for the smaller scale, but this idea of doing something that's bigger. And when he was talking about laboratories, all I could think about was like the music industry and how it's really big for everyone to do a collab. Like, there's one great musician over here engaging with another great musician. And I think that's how I can sort of imagine it. It's getting great players together to do something great.
How do you see that working? Like, can you expand on that a little?
Look, I think it's going to be complicated, but we've probably touched on some of the aspects over the last few days, in the sense of, I think we have to have more engagement with stakeholders across everywhere. We need better communication. I think those two things for me that has been like an underlying theme of everything that we've been talking about. Shared knowledge, I think, is another part, not just these are things we keep talking about, but we actually need to find ways to do them better together.
We're going to go back to the beginning. So one of the things that Noah said was we've got growing literature and stagnant science. It's quite a compelling observation to make. Should this be challenging us to rethink like everything? The emphasis that to be a good academic, you have to be a good particular kind of researcher? Or that if you want to grow your career, the way to do that is to look for the Cat 1 opportunities? Do we have a problem with the way we structure academic and scholarly inquiry that leads to this repeated publication and stagnation of the actual science?
That is what we were hearing earlier. I think it is just more logical. Why use up resources to continue studying something that we already know has impact? And then if you are going to use those resources like he was suggesting, why don't we shift it and start studying deeper elements, comparing different things?
I think in relation to that, you know, from a health service perspective, that's not the goal. You know, when we're talking about implementation and we're talking about practice change and QI, we're actually looking at improving care. And, you know, that's the goal for any health service, particularly, you know, when we're doing those types of projects with clinicians and frontline staff. You know, publishing is always, you know, the secondary goal to that, and sometimes we might get there and sometimes we don't. And I think that's where this spectrum, you know, in the way that we approach implementation across a health service is that, yes, there are some priority areas where we do want to collaborate with maybe university partners in terms of some of the areas. Maybe we do want to provide, have a really, you know, a research framework to that. We're going to do a hybrid study, we're going to focus on this, and it's going to take us, you know, 1 to 2 years versus, you know, no, we want to do this practice change and we need to do it tomorrow. So we need to, you know, we need to weigh that up in terms of what we're trying to do.
So that's a feature of the health system today, isn't it? That imperative, you're always right now.
Yeah.
We need this now. We don't necessarily stop to evaluate. We might collect system level data, but in reality, there's so much that's so fast moving.
Yeah.
So are you saying that a laboratory type approach in a clinical service, like it is feasible, or it's not particularly feasible, or it's just not the main priority?
I think it's feasible, but I think the challenge from a health service perspective where we are currently is that we've got so much data. Most of the time it's retrospective. We're looking at data that's from the last month. We're reporting that data. So, you know, and then we've got this challenge of, you know, frontline clinicians, they don't know how to interpret that data. They don't know what to do with the data, and then it starts again. So I definitely think it is feasible. I think we're just a little way off from being able to achieve that currently.
Could I just ask that, so would something like Noah Ivers' AB approach that he was talking about, where it's, you know, it's a progressive line of learning, I suppose, would something like that work?
Yeah, I definitely see that is something that could be incorporated into the health service and would be really useful for clinicians, particularly given all of the data and the different systems that we have for reporting data as well. It would be useful, yeah.
I agree that I think it's feasible. I just don't think it's the priority. And so if we're going to spend time and energy and resources in the implementation science world, a priority first would be to make sure that we're using the current evidence, right? All of the strategies that we are seeing, and yes, to Sonia's point, there's not just a one strategy that works, and you know, we use audit and feedback. That's one strategy, right? There are many strategies there, and there are opportunities for us to learn on the health system side what standards should we be using in certain situations? What are things we should be thinking about more? And if we're going to spend time and energy and resources in it, that feels like a higher priority than doing a little bit long-term build.
I'm just going to jump in here. Do you think that comes back to Noah's funding? Like, I've literally got notes here that says our funding systems need a shake-up. The publishing sector needs a shake-up. I talked about music before. I feel like a Taylor Swift song. We just all need to shake it up. So do you think that it's they're just funding the wrong projects? That we should have opportunity to, you know, there should be funding projects that give you the time to identify some of these things before you actually get to the doing of things?
Definitely. And I think that goes back to your point earlier about engagement with the stakeholders in those discussions on, well, what are the priorities here? Before we start leaping over to what we want to research and focus on, what are the problems that we need to solve? And let's talk through that and figure out other ways of that collaboration. Maybe that laboratory isn't specifically on this element, but but it's on a different element of implementation science.
And this brings me back to your musicians, I think, because like there's so much resource around health services, including the academic environment where we train undergraduates, you know, develop streams of research and programmatic approaches to inquiry, most of which are attuned to academic needs. And yet there's all the data that you talk about, but the lack of capacity and sometimes the availability of human resources to look into and get that done. So maybe the musicians is just better alignment between potential partnership groups to strengthen some of that capacity. I just want to go with, you know, because you guys, you know JBI's implementation approach, audit and feedback. I would say it's not the implementation strategy. I would say it's the vehicle that carries implementation strategies. So you collect your baseline data. That's an audit, right? Collecting baseline data. And then you do implementation. And then later you collect time 2 and or time 3, etc. So in between there is your implementation strategies. So audit and feedback is the vehicle. But Noah said, who will respond best to what type of intervention is not likely to be answerable in a one-off project? True or false?
Say it one more time.
Fair enough. Who will respond best to what type of intervention is not likely to be answerable in a one-off project?
Due to the amount of variabilities in terms of the context and the...
I'm not giving you more information.
I'll jump in there. I think, if I've got it right, true. I think it comes back to the question here. I think it changes, like everything's changing all the time. So we're not going to find that one thing that's going to work every single time, because healthcare is forever changing, forever dynamically moving, and so what worked the first time may not work the second time. Even in the presentation they were talking about, they were working towards a particular, I think I wrote notes on it, working towards a particular endpoint, and then by the time they got there, that endpoint, the goals had shifted. Yep. So it's this constant challenge. So yeah, I don't think it's...
Yeah, I think the answer is that there is no yes or no answer. It depends on the project and, you know, the size of the project and the context and the culture of where you're trying to make change. And I guess that's the challenges of this work, like, you know, and when you're in a health service, and I know we talked earlier about, you know, the issue of time and resource and stuff. They're still issues now. They're still the issues that you hear every day and that keep coming up. We haven't actually moved beyond that. And that's why, you know, when we're with Noah's present, it is a little bit aspirational for us at the moment to be able to get there. But, you know, with that, there's always opportunity to address these things.
In terms of laboratories and learning systems, you know, we've seen a lot of that. We've seen Sigma 6. We've had a lot of different models that relate to this. And still here we are talking about it today. One of the papers that Noah talked about was a 2016 Lancet publication that looked at how you could differentiate, or how you could assess the difference of interventions, comparing A with B, comparing B with C, so that you could have, like if you had a toolbox of intervention strategies, you could test them against different issues within the same context. Do you think there's some utility there for JBIC to contemplate standardized kinds of approaches to implementation? Because currently it's very fluid and dynamic, isn't it?
Definitely. I think there would be a lot of opportunity in providing that. And something even Alexa was showing in the discussion before about what else can we help clinicians who are doing implementation work with the work that we're doing in JBI. And some of those extra guidance instead of just audit criteria. What are some potential, we're not going to dictate because we don't know their context, we don't know their resource limitations, but here are some thoughts on ways that you might be able to improve your adoption of this new practice change. Here's some strategies that you should think about.
I was just thinking, the whole JBIC is it's like a pool of people that we have access to. We could literally be our own metalab with lots of little labs around. How that works, how you roll that out, I don't know. But I think there's so much potential. At the moment, we run implementation training programs, and it's each entity running their own, to have some collective kind of knowledge and be working towards shared goals. I don't know, I think that learning from each time we run a program in it, learning about different contexts and why something worked in one area and didn't work in another across the JBIC. I think we could do better in that area.
Can we just do a poll? Like, if you'd be interested in something like that, would that interest you, yes or no? Pop your hand up if you think yes. The idea of a toolbox of implementation.
Yeah, toolbox of implementation. Is that what
toolbox of resources to really guide and think through and establish standardized implementation options for clinicians. Yep, all right, someone take a photo because we need to talk to those people afterwards. I think there could be really something interesting in that for us as a global collaborative entity to look at and to do some resource combinations on and do some investigation, couldn't it? Right, where are we now? There's a lot in this talk on some of the challenges in the system, and it's kind of hard to not think about those. But there's another underlying tension, which is, and I think we've all picked up on it, Noah's rightly very focused on randomized controlled trials as the way of establishing what works and to be able to back that out. But we've heard other talks today that have talked about the role of case study because you get deeper into the context. Can I just get your high-level thoughts on the tension there? Where do you sit in that debate?
I have no tension there. I think it's all important, particularly the qualitative realm of things, just for everyone. So I think we need it all, but there's probably a right time and place for doing a particular type of study. We heard Lucy talk earlier about how they had done a lot of quantitative studies, and what was really needed in her area around facilitation was that exploration of the qualitative perspective. So I think it's the same here. There's probably a right time, and I guess the challenge is knowing what is the right study design for you, for your area, for your implementation project.
Okay.
I agree. I think that again, it really depends on the type of project. I think we can learn from, action research, all different types of designs, and I think we need to think broader than just, randomised control trials and those narrow designs.
So before I come to you, because I know you have an opinion, around the room, we've got a huge amount of diversity of expertise and experience. Can I just ask, pop your hand up if you see yourself as a qualitative researcher, primary qualitative research. Yep, there's a fair number. What about, put your hand up if you have, or you see yourself as having experience or expertise to offer in relation to quantitative methods of investigation. Okay, now pop your hand back up if you think it would be useful and interesting for JBI to develop now I've got to be careful with my words, a register, if you like, of expertise across the collaboration with potential capacity to contribute to implementation.
There was a couple of quick hand raisers there.
Yeah. All right, so I think we've got some work we could do, like some groundwork here. Anyway, now can I come back to you about this tension between...
Oh.
Yeah.
The only thing I was going to add is, in addition to this tension, which I also agree that there's space for a lot, is there's space for us to do more of what you were presenting on, which is looking at our implementation reports. What are they telling us? What story can we pull from that we can then synthesize and generate recommendations for our team and others as we do more implementation.
That's a great call. I think there is a lot of room there. I'm going to do that awkward thing again where I want to ask people in the room. So we have a great panel. I didn't introduce them. They're on the app, so I hope you've looked at the app. Just pop your hand up if you want to ask a question of the panel, and I'll come to you. This is... Oh, perfect. Thanks, Rachel.
Fantastic, and thank you again, everyone, for the on the panel. Diane here from Vancouver, Canada. I was curious that you didn't ask about mixed methods research, because everything I do, evaluation, quality improvement and research, is mixed methods, and that's to be able to incorporate principles of EDI and in Canada, Aboriginal perspectives, which are very difficult to quantify, particularly in smaller populations, in evaluation, implementation, and quality improvement. So I was just curious about that.
Yeah, that's guilt by omission, because I've certainly read some really good mixed method studies that are framed in an implementation science perspective. Yeah, Heather.
So I just wondered, it was a sort of question I posed a little earlier in the discussion, but system-wide scalability is a challenge in health systems that are unstable and at the sort of mercy of political winds. And there has to be something, I think, that's a significant win for healthcare services to engage in something that is long-term and scalable, and badged as implementation science, rather than perhaps something that is more patient-focused. And so I wondered if you had any ideas about how we could frame the win more appropriately for clinical partners.
Okay, experts.
I'll just jump in with a thought while you're thinking. Something that I guess I've been thinking about over the last few weeks, and more so this week while we've been having all our discussions, is the importance of knowing who our audience is when we're communicating, and understanding what the value proposition is of what we're offering, what we can deliver, what we're trying to achieve, and presenting that in a language or a format, whatever it looks like, that the audience understands. And I think that's where we probably can do a bit more work in when we're talking to the funders, we mean this and we frame it this way. When we're talking to patients, it looks like this and it's framed that way. When we're talking to health services and trying to get them engaged, it might look like something else. I mean, I don't have the answers on what that looks like, and perhaps that's a co-produced, I'm not sure, maybe that's the way that we go, but it's just really, I can just see the importance of having to not just have a single output or a single way of communicating a message, but communicating it in many, many different formats targeted to the particular audience.
Yeah, I think that's a great question around scalability, because we certainly have that challenge in a large health service that's statewide. You know, a lot of projects that we try to do across facilities and across organisations, are often driven by, our quality and safety data, our clinical incidents. That's where we get the biggest buy-in, and from leaders and from the executive in terms of being able to have the time to address that, and the resource to address that. And I think that comes back to my point around that spectrum of approaches to implementation. We might work with smaller areas on a smaller problem, but then for scalability, it really has to be driven by health service priorities. And then at the other end, we have projects where we might be applying for funding, or we might be part of a partnership grant. And again, it's attractive for health service organisations because there's funding attached to that, and there's support from university partners. Other health services are involved, so we get buy-in that way for those larger type projects.
Yeah, I love the question too. The only other thing I'll add, because I completely agree, is Oftentimes when we do local implementation work and it's successful, and then we try to spread it, we take two specific strategies. One is we look for what, the term, we all know the term ROI, but we look for the VOI, which is the value of the investment, and we help with the teams that we're going to implement on, how is this going to be valuable for you, right? Instead of just receiving some new best practice from on top of the best practice that we rolled out 2 days ago, right? And then the one we're still trying to implement from last week, what's the value of this particular intervention? And one of the ways we get there is through patient stories. And we tie this best practice to a patient who we get a story from on, wow, this is where the impact comes in. So it doesn't just feel like a business transaction of us keep implementing. We connect it back to why these teams are here. And those stories really do a lot for engagement and the value elements.
We're going to need a new acronym, VOI. Was that it? VOI.
You got it.
I've got it. Right, we have a new acronym in JBI. I haven't had one for 10 minutes, so that's good. We're going to finish this session here. It would be great to keep talking, but we can talk over drinks later on.